Good morning and welcome to the San Diego Spine Foundation Lecture Series. As you know, every week we just have either speakers from our that are homegrown versus those that we get to invite into our mix. And today we're honored to have Jeff Hills with us to talk with us about being more precise with our alignment targets, sort of almost probably regardless of what type of surgery that we're doing. So, Jeff, we're so honored to have you with us today, and so grateful to be able to listen to kind of the guy that's been writing the text on this whole process with the pelvic angles. And do you mind just sharing with us the 3 points that you're going to kind of keep as takeaways for us?
Yeah, thanks for having me. I would say three big takeaways are to avoid categorization of continuous measures at all costs. I think it's time to retire metrics like PILL, mismatch, and SVA, and really work towards using more precise alignment targets that describe regional and global alignment. And right now, what what I've been using is L1PA target equal to 50% of PI minus 20, and a T4-L1 PA mismatch close to 0 will give you aligned thoracic and lumbar alignment.
Awesome. Well, we're looking forward to hearing your talk this morning, and thanks everyone for tuning in.
So I'm going to talk about working towards precision alignment targets. So a few of the learning objectives describe what's necessary for patient-specific quote, ideal surgical plans, discuss sagittal balance and alignment, limitations to traditional goals, and understand normal sagittal alignment and alignment targets based on normal. So first, patient-specific surgical plans in adult spinal deformity. So what is the ideal plan? We often say ideal surgical alignment targets, and I don't love that because I don't think we know what ideal is. If it was truly ideal, we would never have failures, but it's important to understand that everything that we do has a cost, and I mean risk of complication when I say cost. So malalignment has a cost and perfect alignment has a cost. And we have to try to balance those things. So describing what range of perfect alignment is a goal of most of this talk. So the goals of ASD surgery are challenging because we have to balance multiple objectives with surgery, right? We have to balance the risk of complication, surgical constraints, we have to achieve sagittal balance, and somewhere in there, between all these things, is the ideal plan. So again, everything that we do has a cost, and for the truly optimal plan, we first would need to predict the odds or cost of multiple objectives. This is just made up, so don't pay attention to this. This is just I'm kind of taking an overview approach right now of what we need to do in order to find the truly optimal plan. And, optimization is a computer's approach to cost reduction. So minimizing cost will help work towards identifying the truly optimal alignment. And so right now we're talking about identifying optimal sagittal alignment. So for example, if we started with every possible alignment strategy there is, and then we assign alignment constraints, so just for example, using T4-PA and L1-PA, that would narrow us down to a certain range of alignment possibilities. And then if we say, okay, now we also have surgical constraints, like the patient's fused from L3 to L5, then that would narrow us down some more. And then we'd have a range of alignment plans that we could choose from, and that would be the alignment plan. So first, we need to define what is the acceptable alignment, in which the cost of more malalignment would be unacceptable. So now just stepping back and thinking about what normal sagittal balance is. So Dubosset described the cone of economy, which is a stable zone of upright standing posture. And the goal of this is to stand upright efficiently without expending a lot of energy. So normal sagittal balance and alignment is determined by spinal alignment, pelvic tilt, and lower extremity alignment. Okay, so if you have malalignment of the spine, then you will use compensatory pelvic retroversion and knee flexion in order to stand upright. But that takes a lot of energy, and people will fatigue quickly when doing these things. And if you didn't have those compensatory mechanisms, then you would fall out of that cone and eventually fall over. Okay, so that was in 1994 that Dubuisset described the cone economy. So just now looking at a historical overview of our current uh, alignment strategies over the last few decades. So in 2005, Dr. Rusoli described his classification system, which described 4 types of lumbar spine shape based on sacral slope cutoffs and lumbar apex of lordosis. And in the last 5 years or so, they updated this classification system to include a type 3 and everted in addition to the traditional type 3 spine. In 2011, the SRS Schwab classification was published, and that really emphasized the relationship between lumbar alignment and pelvic incidence. And they used the correlations between disability and these 3 parameters to describe the alignment goals. So an important thing to point out when it comes to these targets, PIL mismatch is the only directly modifiable parameter within these targets. So it's the only one that you can measure intraoperatively and know what it's going to be whenever you're done with the surgery. And there's an issue with it. So PIL mismatch. So these are the 5 just animations of L1 to S1 lordosis at 50 degrees for a PI of 50. So PIL mismatch is 0 for all of these different shapes of the spine. And you can see that puts you at a very different position. And this doesn't even include patients with multi-level step spondylolisthesis like this, which would even change you more. But these different shapes of the lumbar spine, despite all having a PIL mismatch of 0, will put your head in a very different position. So it's not real specific, and whenever people found that okay, even if you realign somebody to a PL mismatch of 0, they're still having a lot of complications. So in 2016, age-adjusted alignment goals were reported, and so what they did in this paper was determine normal quote normal disability by age, and then correlate that to new alignment targets based on disability and age. So there's some other issues along with that approach. And then in 2017, the GAP score was published, which described 3 different categories of alignment ultimately after you add up the points for each parameter. So we've had several different strategies over the last few decades. How have they generalized to other cohorts? Well, not great. So there's been several papers trying to reproduce these results, and they've been inconsistent and not consistently shown improved outcomes. And so what are the limitations? Well, I'd say number one, all of our prior strategies here have been based on classification. They all use postural measures as targets, and targets were developed using abnormal spines. And this is the point that I'd really emphasize over and over and over again. And I really try to drill into our residents here is that these are all based on classification, which is just never going to work. We're never going to get towards truly precision alignment targets in precision medicine if we're taking that approach. So patient-specific alignment goals must be based on risk and probability models, not classification. So if you look at an example like this, say we have 50 patients and we're looking at whatever alignment metric you want to pick, and then we have complications or disability or pain or whatever on the y-axis. Okay, it's important to understand that whenever we study these patients, we're trying to take this very small sample of patients, 50 patients or so, and make generalizable conclusions that will apply to the rest of the population at large, so the rest of the world. Okay, so when we draw lines and arbitrarily make these different categories, we're assuming that each person in this bucket, they're all the exact same, which we know is not true, right? These people are that are right bordering that threshold are essentially the same, but we're treating them as completely different if we draw these arbitrary categories. So categories do not exist in the real world. Whenever we really look at the data, it doesn't exist. So they're totally made up, they're arbitrary, and it just results in imprecise planning. And classification will inevitably always lead to misclassification. So we need to try to work away from this. And I would encourage you, if everyone on this, to just Google classification versus prediction. Frank Harrell has an excellent article on this topic, and it can explain this in more detail. So, stepping back, what's our overarching hypothesis is that realigning somebody to a normal physiologic shape will lead to improved patient outcomes and fewer complications and a lower cost. But first, we need to go back to the drawing board and define what is normal. And that was what our goal was with the next paper I'm about to discuss. So we looked at patients that had no degeneration or deformity. We excluded asymptomatic volunteers that had scoliosis or signs of radiographic signs of degeneration. So, sorry. So the first step in establishing alignment targets based on normal is to define what normal alignment is using parameters that are directly modifiable in surgery. And then step two is asking the question, does realignment to normal improve outcomes in ASD patients? And so this was the paper we published a few years ago. It was a multinational cross-sectional study of volunteers over 18. And like I said, we excluded anyone with disc degeneration or spondylolisthesis or scoliosis. So we studied 320 volunteers from all over the world. Median age was 37, 60% were female. These are some of the radiographic parameters that we measured. So we measured sagittal Cobb measures at every level, vertebral pelvic angles at every level, and pelvic tilt and C2 tilt. And so the way I think about this, at least, is that these are measures, the sagittal Cobb and vertebral measures are measures of sagittal alignment, and C2 tilt and pelvic tilt are measures of sagittal balance. So C2 tilt is also known as the odontoid hip axis, but you draw a line from the center of the odontoid to the center of the hips and then a vertical line. And this is independent of independent of pelvic incidence, and everyone really tries to get a value close between -1 and -3 or so, and I'll show you that as well. And the nice way of, or the nice thing about looking at it like this is that C2PA equals C2 tilt plus pelvic tilt. So we looked at all of these measures by pelvic incidence, and what we found was that pelvic incidence was really insufficient for defining a normal lumbar lordosis. And the range was quite wide, up to 20 or close to 20-degree range of normal by pelvic incidence with an R squared of 0.3. And as you go down in the lumbar spine, so L5-1, L4-1, etc., the relationship with PI becomes even weaker. And one thing I'd note is that there's been several papers describing a normal L4-S1 as being static at around 35 degrees. I would, I wouldn't totally agree with that. The normal range of L4-S1, as you can see here, is between 25 and 50 degrees. I would say it's independent of pelvic incidence, but that's very different. Saying that the average is 35 degrees is very different than saying that everybody needs or a goal for everyone should be 35 degrees. So when we looked at L1 pelvic angle by pelvic incidence, we found a much stronger relationship between these two measures. So the R squared was almost 0.6, with a normal L1PA being described by this equation here. So 50% of PI minus 21 with a range of 4 degrees in either direction. And so when we put all of these things together, it's the vertebral pelvic angles and sagittal Cobbs and vertebral tilt, and uh, describe it in relation to pelvic incidence. You can see that most of the changes in pelvic tilt and all our alignment parameters really come in the lumbar spine. And if you draw a line from T4 to the hips, it crosses over L1, and that's what we described it, and that's what we called it in the line T4-L1 hip axis. Because the T4 pelvic angle and L1 pelvic angle, independent of pelvic incidence, was very strongly correlated with an R-squared of 0.9. So again, a normal sagittal spinal alignment is based on these pelvic angles. Normal L1PA is 50% of PI minus 21, and the T4-L1PA mismatch between -3 to +1. And there's a wide range of normal PILL, and C2 tilt is between -1 to -4. So step 2 was to ask the question, does realignment to a normal T4-L1 hip axis improve outcomes in ASD surgery? And this was a paper that we published this past year. So we studied a multi-center ASD registry and included patients that were instrumented from the upper thoracic spine to the sacrum or pelvis. And that was because we wanted the T4-PA to be completely controlled within the surgical construct. Our variables of interest were deviation from a normal L1PA and the T4-L1PA mismatch and age. And our outcome of interest was failure in the sagittal plane within 2 years. So PJK or displaced rod fractures or revision surgery for either of these things. So we identified 247 patients, median age was 64, 27% failure rate. And this is what we found. So on the x-axis is deviation from a normal L1PA, and on the y-axis is probability of mechanical failure. And we modeled these parameters non-linearly, and what we found is that as you deviate in either direction, so under or over correction of your L1PA or T4-L1PA mismatch, the risk of mechanical failure goes up. And the lowest risk was with an L1PA equal to 50% of PI minus 19, plus or minus 2 degrees, and a T4-L1PA mismatch between -3 to +1. This is just another way of looking at these data, breaking it up into under and over correction of L1PA and T4-L1PA mismatch. And you can see that those at target or at normal had the lowest risk versus people with T4 ventral to L1, so T4-PA greater than L1PA, and under correction of the L1PA had a 50% risk of failure within 2 years. So again, major takeaways, hopefully from this talk, is to avoid categorization of continuous measures. If our goal is to work towards precision alignment targets, we really cannot. There's no role for categorization of continuous measures of alignment. And I think it's time to retire measures like PIL mismatch. It's imprecise. And same with SVA. SVA is associated with pelvic incidence, and I think measures of balance, better measures of sagittal balance or C2 tilt, and really work towards using precise alignment targets. So working segmental to regional targets that will achieve a normal global balance. And so the regional targets I think that I'm using right now are L1PA equal to 50% of PI minus 19, and T4-L1PA mismatch between -3 to +1. And again, reemphasizing that patient-specific plans must weigh the cost of all options. So malalignment has a cost, and perfect alignment has a cost, and we have to try to balance these. So how do we correct? So to achieve these regional targets, how do we get from the segmental alignment to regional these regional targets? So just as an example, let's say we have somebody with a PI of 60 that has a prior fusion, and their L5-S1 lordosis is flat. They have some thoracolumbar kyphosis. So with a PI of 60, L1PA target would be between 9 to 13 degrees. Currently, their L1PA is 22 degrees. So if we correct the segmental alignment at L5-S1 by adding 20 degrees, that'll get you to an L1PA of 10. Now we need to correct the thoracolumbar kyphosis. So currently the T4-PA is 15 degrees. By correcting the thoracolumbar junction, that'll bring us down to 9 degrees and align the T4-L1 hip axis. So if we have time, I think so. So how can we estimate their postoperative pelvic tilt? This is another paper that I wrote with Gotham when he was still here. So explaining the change in pelvic tilt after long spinal fusions using this equation. So C2PA equals pelvic tilt plus C2 tilt. So really leveraging this geometrical relationship to understand why somebody's pelvic tilt might change after surgery or why it may not change. And what we found is that with increasing C2PA, pelvic tilt will increase but in an attempt to maintain the C2 tilt until it reaches a quote maximum pelvic retroversion. And at that point, it'll start to fall forward. All right, so if we had time, I was just going to show a quick case, and then we can do any questions you guys have. So this is a 55-year-old female that came to me with this deformity that had progressed pretty rapidly over the prior 1 to 2 years. So her PI is 41 degrees, pelvic tilt is 14, C2 tilt was positive 14 degrees. L1PA was 10, T4PA was 27 degrees. So this is her myelogram. So you can see she's pretty flexible throughout her whole spine. So for her, she's fairly young. I really wanted to aim to get her perfect. So this is my plan. So L1PA goal was 2, and T4PA goal was 2 as well. So I did an all posterior approach for her, given how flexible she was, and just did a T-lip at the bottom and T4 to pelvis to realign, to get her corrected coronally and then align her T4 L1PA, and she's about 6 months out and doing quite well. All right. I know that was kind of a lot, but any questions?
That was a great doc, Dr. Hills. Um, you mentioned for, lumbar lordosis, not everybody should be getting, 35 to 40 degrees, but for, those people out there who, aren't either getting full length films or, they're just addressing 1 or 2 levels and not really thinking about it. They're saying, I got to get 40 degrees. What do you suggest um, they do, 'cause I
Well,
feel like,
yeah. Um, my first thing would be to say get full spine films. You wouldn't fix a distal femur fracture without full femur films, right?
yeah,
So image the full spine to see what you're dealing with, and then I just say that for most people, for the majority of people, if you have 35 to 40 degrees of lordosis from L4 to S1, you're probably going to be okay for most people. But there are a subset of people that may need more or may need less. Maybe it's 5 to 10% of the population. I'm not going to have a great answer other than just to get towards precision targets, alignment goals, we can't just use averages, right?
yeah,
1% of the population has the average. The average is 35 degrees, but 99% of the population will have more than that and or less than that, right? The
yeah,
average is a sliver of the population. So it's important to understand that not everybody has 35 degrees of lordosis from L4 to S1. Most people actually do not. That's just the average. So if we want to get towards precision, patient-specific goals, we can't really think about it like that.
yeah,
Hopefully that answers your question.
yeah,
But I mean, I would say, if you're, I mean, hopefully with more progress on this in the next few years, studying acetabular version and full alignment, we'll be able to get closer to something that, and using biomechanical simulations, I think will help get us towards precision targets that minimize risk, but we'll never get to zero risk.
Right. Dr. Hills, this is Yusuf, one of the spine fellows. Just a question about kind of pelvic tilt compensation, and you touched on this a little bit, but I was wondering what your thoughts are on this, the supposed kind of pelvic tilt non-responder group, the patients who, when you do a beautiful alignment, correction, you hit your goals, but still they're imbalanced, I'll call it, because, as you mentioned, pelvic tilt is a function of balance. So can you kind of touch on that and what your thoughts are on that?
So, yeah. So I should let Gotham answer it, but
No, we just got to show that slide.
Yeah, I think that
Please don't.
Yeah. I think that we tried to kind of debunk that theory. I don't like that. I don't love that term pelvic tilt non-responder. It just sounds kind of like we're blaming the patient for something that we don't understand, right? So I think there are some people that we have trouble predicting what their goal or what their C2 tilter is going to be. Some elderly patients, I think, do tend to want to drift a little forward, which will change their pelvic tilt. But I mean, 99% of people, if you measure their C2 pelvic angle or your planned C2 pelvic angle, you'll be able to explain why they did or did not retrovert their pelvis. A lot of the times, if they start to PJK a little bit, that'll increase their C2 pelvic angle quite a bit, and you'll see that their pelvic tilt starts to go up. But for the most part, it's under correction, I think, or correction in the wrong place if they're still compensating with high pelvic retroversion. But if you read that paper, we really try to give a clear explanation of that and some examples.
Great, thanks.
I do think the other thing on those lines, you have to pay attention to, Yusuf, is like, again, right now we're looking at two-dimensional images to extrapolate findings from, right? You have to I mean, it sounds stupid here, but like you have to examine your patient. Like if they have like, terrible psoas weakness, or if they have terrible posterior chain weakness, these are patients that probably have an inability to manipulate their pelvis as well as someone that has an intact pelvic girdle. So when you see people walk and how they stand, et cetera, if they have good gluteal function, you'll get a sense on whether these patients are able to, manipulate their pelvis or not. And then the other group that I think is actually pretty interesting is the group that's had total hips, because they go from having arthritic stiff joints to all of a sudden having a fully mobile joint. And I sometimes see those patients have almost too much movement in their pelvis, and they don't quite know what to do with all of that as well. And I have a few examples of that too. But I think Jeff's point is very well taken, which is like, as far as what you can control, he's showing you that. Some of those other things we can't quite control, right? And we're sort of left, and where you'll end up, plugging that calculation in for risk at some point. Patients that have bilateral hip replacements, or patients that have terrible hip arthritis, or patients that have had a bunch of their femoral acetabular angles been off, and they've had a bunch of osteopathies for it. It's a different group.
Yep. One thing about the only other thing I'd add to that, Greg, is that I think you can capture a lot. I think those things do matter, definitely, but you can capture a lot of that using their preoperative pelvic tilt. So, there are patients that you might look at their pre-op pelvic tilt and not really understand, like, why are they not standing right? Or, why don't they just retro? Like, I have a few patients that have horrible hip flexion contractures, and I look at their x-rays and I'm like, why don't they just retrovert their pelvis and stand up? And then I go and examine them, lay them on their back, and they can't get their hips beyond about 45 degrees of hip flexion. So, but I would know that preoperatively, right? I would know that before we did anything to their spinal alignment. So most of those things I think will be captured what their preoperative pelvic tilt. So change in pelvic tilt is what that other paper was getting at. So, and I think most of that, is really just from change in their C2PA. Or pain can influence it also, obviously, if they have lumbar stenosis, that you'll see them leaning forward. But anyhow.
Do you use anything like sitting x-rays ever to evaluate these
You know,
patients?
I used to get them, and then after SRS, and I didn't really understand how to evaluate them, to be honest. And then after SRS last year, I started getting them again, and now I'm back to I don't know really how to interpret them. Like I mean, there's some theoretical like things, but I don't totally know how to interpret them. That it might help. Show you what is like uh, due to pain, maybe, but I'm really not sure how that totally helps us. I think examining them, make sure they don't have hip flexion contractures is important, but I think that's pretty rare actually.
Yeah, nice work. Question. For many years, decades now, we've had all of these factors weighing on failure. We've assumed they've been more or less one or the other, and it's not until recently now that we may have more appropriate patient-specific guidance on how to shape a spine. How long do you think, statistically speaking, do you think it will be before we really have properly aligned patients so we can vet all this other stuff like sarcopenia, bone health contributions to failures when previously everything was sort of lumped together and we weren't doing anything very well, alignment or patient prep?
Yeah, it's a major challenge of this area of research is that the data availability, and I mean the most important thing is that we have quality data, right? That we're accurately tracking our outcome. I mean, you can have 10,000 patients, but if you're not really rigorously tracking your outcomes and your PJK rates and your pseudo rates and all these things, those 10,000 patients don't mean anything. So I don't know the answer to that. I mean, I think if we had 500 to 1,000 patients, we could probably generate pretty accurate data, but it would have to be it needs to be very granular data and very accurate outcome tracking. And I mean, these are really tough patients to study because, if you have a take back, not all take backs are the same. If you have an error that is our fault for off the top of my head, I can think of a patient that I had to take back that was my fault. I did one iliac fixation, distal to a long fusion, didn't have an S1 screw. The thing popped off. That was my fault. That was not an alignment issue. That wasn't anything else. But so if that gets tracked as a mechanical complication due to alignment or something like that, then I don't think that's quite accurate. But so these are really hard things to study, really hard things to track. And like I said at the beginning, everything has a cost. One kind of argument that people often stand up and say is that, well, if this is a 75-year-old patient, if you're going for perfect alignment, then you're going to have to do a PSO or something like this. And I mean, I would say, yes, like that, and there's risk with that. There's a huge cost to doing a PSO, but there's also a cost to malaligning them horribly. And I could show another example that I thought along those lines. I was like, she's okay aligned. I'm not going to do a PSO. So we'll just extend her up like she had a prior T10 to pelvis. So we're gonna accept some malalignment, with my thinking being that was lower risk than putting her through a PSO in this huge revision. Well, I extended her up, then she PJK'd, then I ended up having to do another extension and a PSO to begin with. So the cost in that case, the cost of malalignment actually was much higher than the cost of just doing the PSO the get-go. So I think that's the important thing to understand, and we have to also balance the patient's risk tolerance. So we'll never be able to have a computer program that we can plug in a patient X-ray and have them tell us what to do. That's impossible because it has to be developed with the patient sitting in front of you, because what's the patient's risk tolerance? How disabled are they? Are they willing to, we've all had the patients where they say, I'd rather be dead than continue living like this. And we have to do something. And then you say, okay, well, we're going to do this huge surgery despite the fact that you're maybe not the healthiest person. And then there's other people that might be content with, you know what, I'm okay in a wheelchair, I'm fine. And then their risk tolerance is not the same. So we can't, we'll never have a computer that'll tell us exactly what alignment to put somebody in, because it has to be, each patient is going to have to be specific, or each plan will have to be specific to the individual patient. But it's going to take a lot of data, thousands of patients, and some computer assist, AI or machine learning assistance in that area as well.
Thank you.
Well, thanks, Jeff. Appreciate your time.
Yeah, thanks for having me.
Thank you so much.
Thank you.
See you guys.
Yeah, thanks, Jeff.
See you, man.